My dear students, in this video, I am going to discuss some salient points about a relatively new concept, which is VABI or ventilator associated brain injury. Although this concept has emerged over the past few years, there are certain points which still require validation, and still there more studies are expected and awaited to give finer description of this condition. Let us start with this case. A 62-year-old male with septic shock and ARDS. The patient is on ventilator with a tidal volume of 6 mL per kg. PEEP is 14, respiratory rate is 28, and the PCO2 is allowed to go up to 55 millimeter of mercury as a part of pervasive hypercapnia. After 48 hours, the patient becomes deeply delirious, the ECG showing diffuse slowing, and MRI shows hippocampal edema. Now, this is a classic VABI without primary brain disease, where there has been hypercapnia, which led to cerebral vasodilatation. This caused increased ICP, leading to reduced CPP. There was lung biotrauma because this is an ARDS patient. Cytokines cross the blood-brain barrier, giving rise to microglial activation and giving rise to hippocampal neuronal apoptosis. And there was also high mechanical power because the respiratory rate was high. So that multiplied by driving pressure and the tidal volume. So all of these were responsible, and it inks to the possibility of a classical ventilator-associated brain injury. Now, what is this brain injury and how we define it as per our current knowledge on the subject? Now, this subject was discussed at length in 2024 May issue of the American Journal of Respiratory and Critical Care Medicine, where certain points were clarified and certain points were mentioned that they require further studies. And although some studies are already ongoing, they require validation. So VABI is defined as de novo brain injury or dysfunction, which is resulting directly from the application of positive pressure mechanical ventilation and which is not attributable to co-interventions or confounding factors such as the sedation. Now, preclinical studies have shown that positive pressure ventilation per se can cause acute inflammation and cellular apoptosis in multiple brain regions. Now, this is the root cause for ventilator-associated brain injury. In animals without antecedent brain injury, this positive pressure ventilation impairs the blood-brain barrier function, and thereby it induces neuroinflammation and hippocampal apoptosis. So whereas in one form of the patients who already have a pre-existing injury of the brain, so in them there can be multiple causes, but these patients who are not having any other reasons for brain injury, these patients can also get affected during positive pressure ventilation. And the resulting neuropathology is very similar to that of Alzheimer's disease. If you look into this diagram, you can clearly identify that in one group, one set, you have primary brain injury in patients without established brain injury, that is called the VABI. And on the other hand, you have secondary brain injury in patients with established brain injury. So both are brain injuries. So it is only the primary form that qualifies as VABI as per the current definition. In the secondary brain injury can be because of reduced brain venous return, cardiac output, reduced CPP, tissue hypoxia, and all those. And those similar, these effects may occur even in primary, but because of there is no affection of the brain primarily, so they do not qualify. The secondary brain injury do not qualify to be defined under the present guidelines of VABI. And if you look into the clinical manifestations, they are also similar, that in that there can be delirium, coma, disability, impaired quality of life, and long-term cognitive impairment. Now, what are the pathophysiological mechanisms? And these mechanisms will be common to both secondary brain injury and the primary injury or the VABI. That one is the cerebral hemodynamic effects because of increased intrathoracic pressure during positive pressure ventilation, giving rise to increased JVPs, reduction in the cerebral venous outflow, thereby causing an increase in the ICP, and as because we know that the cerebral perfusion pressure depends upon the difference between the MAP and the ICP, so there is a fall in the cerebral perfusion pressure. So high PEEP and high plateau pressures are the key drivers for this effect. The altered PCO2 is the major mechanism, and it is more important mechanism than the increased intrathoracic pressure. We know that whenever there is hypercapnia, there is cerebral vasodilatation giving rise to increase in cerebral blood flow with increased ICP, and whenever there is hypocapnia, there is cerebral vasoconstriction due to attempts to reduce cerebral blood flow and ischemia. So it is the cerebral vasodilatation during hypercapnia which is primarily responsible. So third is the oxygen toxicity and hypoxemia. Hypoxemia secondary to ischemic brain injury, or hyperoxia leading to oxidative stress, cerebral vasoconstriction. These are also harmful. Neuroinflammation, or the because of lung stretch, there is cytokine release, IL-6 and TNF alpha. There is systemic spillover, and that causes microglial activation, blood-brain barrier disruption, and neuronal apoptosis. So this can occur even without hypoxemia, and so they may get undetected or unnoticed in the ICU patient. And the last but not the least, the important factor is mentioned in the case also, the mechanical power and the shear stress. If it is high tidal volume, driving pressure, or the respiratory rate puts a greater inflammatory load, and therefore there is more stretching and more shear forces active in the lungs. So there is more brain injury signaling. So now, what are the clinical settings where this ventilator-associated brain injury is relevant? One, in patients with severe traumatic brain injury on high PEEP, in ARDS patients with preserved brain, in post-cardiac arrest, in septic encephalopathy, and in patients with ECMO with aggressive ventilation. What experimental evidences show is that in animal models, there is lung overdistension, and this lung overdistension leads to hippocampal apoptosis. And alongside, there is also increased microglial activation. What the clinical evidences point out to, the observational studies which have been taken out so far, they have shown that high driving pressure is associated with delirium and poor neurological outcome. Hypocapnia in traumatic brain injury is linked to higher mortality, and excessive PEEP increases the ICP in low compliance breeds. So all of these factors are important, and this requires are relevant as well as important, and this should be taken care of to prevent VABI in the ICU. So what are the practical ICU implications during neuroprotective ventilation which we tend to practice? One is that in cases of TBI or subarachnoid hemorrhage, we keep a PCO2 target somewhere between 35 to 40 based on the observational studies. Raised ICP, we avoid less than 30 unless there is risk of herniation. In ARDS, along with brain injury, we try to keep the PCO2 between 35 to 45 and make it more individualized so that and rather than going by the rule of the thumb. In the PEEP strategy, we use the lowest PEEP that maintains oxygenation, and we have to monitor the ICP, the CPP, the jugular venous distension. Always prefer recruitment by FiO2 before excessive PEEP in brain injured patients. That goes for secondary brain injury. The practical ICU implications also include tidal volume and driving pressure. We know that the tidal volume should be to be around 6 mils per kg of predicted body weight. Driving pressure should be less than 15 centimeter water, and the plateau pressure should be less than 28. Oxygen targets, one should avoid SpO2 of less than 92% and PO2 of more than 120 millimeter mercury for prolonged periods, and target the PO2 between 70 to 100 because that is considered to be safest for the brain. For sedation and synchrony, poor synchrony leads to swings in PCO2 and ICP. So we should prefer short-acting agents, adequate analgesia, and avoid deep unnecessary sedation. Now, what are the differences between villi and VABI? So the villi is the primary organ is the lung, VABI is the brain. The mechanism is barotrauma or volute trauma, particularly in villi. It can be biotrauma also and atelic trauma, no doubt, but primarily it is baro and volute trauma. In VABI, it is the ICP, the CPP, and the inflammation. The biomarkers are neuron-specific enolase, S100 beta protein for VABI, IL-6 SPD for villi. The clinical manifestations are usually ARDS in case of villi. In VABI, it causes delirium, coma, and poor neurological recovery. Now, there are some scope for potential therapeutic strategies already, which are ongoing research, and some progress has been made. First, anyways, it says that avoiding high driving pressures may attenuate VABI by limiting the lung stress and strain from positive pressure ventilation. And secondly, pharmacological or neuromodulatory approaches have been proposed, like pulmonary stretch receptor antagonism by nebulized lignocaine, pulmonary purinergic receptor blockade, which is achieved by intrathecal administration of an experimental drug, that is isopepads tetrasodium, that is again also in a preclinical models. Olfactory bulb stimulation, a lot of reports are already there, or diaphragm stimulation, all of which might be evaluated in future randomized control trials. The findings suggest overall is that spontaneous breathing and or olfactory bulb stimulation under assisted ventilation may protect against VABI. Now, many people have done different ways of this olfactory bulb stimulation. What is the ideal method? How long should be done? And what should be the frequency? That requires further studies and further trials. So right now, we only know that olfactory bulb stimulation may be one of the potential strategies by which it can be prevented. So some people have also proposed a brain lung protective bundle, which looks into lung protective ventilation. And alongside it also looks for normocapnia, normoxia, ICP guided PEEP strategy, and minimize or the minimal mechanical power. So at the end, the take-home messages on this account of VABI would be that so far we had known about ventilator-induced lung injury, we had known about ventilator-induced diaphragmatic dysfunctions, but yes, this is also a real entity which exists. We need to know more about this about this pathology and its modus, how it is presented, what are the finer points or what are the finer adjustments that are possible in the ICU to prevent VABI. So the ventilator is a neuroactive device. The PCO2 is the most powerful ventilator medial determinant of the brain injury. High PEEP and driving pressure can worsen ICP and CPP. Lung trauma, biotrauma causes real structural brain injury, as I've noted, because of the hippocampal apoptosis and neuroinflammation. And neuroprotective ventilation should be standard of care in all brain injured ICU patients and also in non-brain injured ICU patients. Always we have to remember that we have to protect the lungs, but never at the cost of the brain. Thank you.